Hello everyone and welcome to our slideshow on degenerative disc disease. Degenerative disc disease is an age-related condition, but it can also be due to trauma or genetic predisposition. This is when one or more of the discs between the vertebrae breaks down. The rubbery discs in between the vertebral bodies normally allow for flexing and bending of the back. They act as shock absorbers. And in time, as you age, they become worn out and they no longer offer as much protection as they used to. This all leads to pain, and the most common places where this happens are the C-spine and the L-spine. If a patient experiences sudden onset of neck or back pain, their family doctor might refer them to a spine specialist, who will then begin to ask questions related to family history of back pain, as well as other diagnostic questions about symptoms and the intensity of pain that they're having. A physical exam can also be done by the doctor just to feel the spine and make notes about the curvature and alignment. Imaging tests can also be ordered. X-rays can be ordered to have a look at the vertebral column and the alignment of the vertebrae. MRI scans and CT scans can also be ordered to have a look at the soft tissues and if there's any pressing of nerves that can be causing the pain. The outlook of degenerative disc disease just depends on the severity of the pain and whether or not the person is responding to treatment. And the pain does not, the level of pain does not increase with age. And it's believed that in the first 3 months of having this pain, 90% of symptoms will subside. Some signs and symptoms may include pain that worsens when sitting, bending, lifting, or twisting spine. You can have periods of severe pain that come and go. This can last from a few days to a few months before getting better. This pain can range from nagging pain to disabling pain and can affect the lower back, buttocks, thighs, or the neck, and the pain can also radiate to the arms and hands. This just depends on where the disc is. You can also have numbness and tingling in the extremities. You can have weakness in the leg muscle or foot drop, which is a sign of a damaged nerve root. There are several treatment options for degenerative disc disease, such as physical therapy, which has or involves specific movements that make the muscles in your neck and back stronger and more flexible, and this supports the spine. Exercising can also help patients feel better as opposed to sitting or standing for long periods of time. Some other options are over-the-counter medication such as aspirin, which can ease the pain and lessen the swelling. If needed, there are stronger medications like steroid shots to ease the pain, swelling, and inflammation. Spinal surgery is usually the last resort, and this is only considered if non-surgical methods have been implemented for months with no changes in pain. This surgery involves removing the damaged disc, and rarely an artificial disc may be used in order to replace the damaged disc that has been removed.
Imaging methods are X-ray, which include 3-foot standing lumbar X-ray, AP or PA, lateral, flexion or extension, CT scan, MRI scan, EMG, and further tests which include bone scans, discogram, and myelogram. Overall, X-ray is a poor imaging method for assessing soft tissue structures, but it will demonstrate a narrowing of the space between the vertebral bodies. It could therefore possibly indicate whether a disc has become very thin or whether it has collapsed. There's also a flexion extension X-ray, which provides enough information about movement between the vertebrae as it requires the patient to bend forward and backward. There's also a 3-foot standing X-ray that requires AP images of the spine, or lateral X-rays, which provide details about spine alignment. CT scans can show many details of the osseous structures and the calcifications, but it is of a higher cost and exposes patients to radiation. The multi-detector CT could be utilized as it is useful in evaluating spine alignment. Also, a CT scan makes it easier to depict bones and nerves effectively to assess whether a bone spur is pressing onto a nerve. MRI is the best tool for diagnosing lower back pain. So on this image, this is an MRI of the lumbar spine. It's a sagittal T2 weighted image, so you can see the loss of white signal in the L5 body. And so what this means is that there's also an increase in signal on T2 images, and this means that there's a loss of hydrogen ions. And also, an anatomical detail is best seen on T1 weighted images due to the high SNR.
There are three main MRI sequences of the lumbar spine. The first one is sagittal T1 weighted spin echo sequence. This sequence is not the most sensitive to pathology, but it showcases the best anatomy as it has the best signal to noise per unit time of scanning. In this sequence, tissues with short T1 times, like subcutaneous fat or fatty bone marrow, appear bright, whereas tissues with long T1 times, like fluid and cortical bone, appear dark. Sometimes, to avoid the bright fat signal that may obscure important imaging findings, a fat-suppressed inversion recovery sequence, short for STIR, may be added to the images, which causes fat to appear dark. The image on the right showcases a T1 weighted images with STIR applied, which causes the fat in the image to appear dark. The second sequence is sagittal T2 weighted spin echo sequence. This sequence is the most sensitive to pathology. Sagittal T2 weighted images provide excellent contrast between CSF and the fecal sac and the surrounding structures, allowing for assessment of the degree of spinal stenosis at multiple levels on a single image. This sequence is also used for assessment of the intervertebral disc for the presence of disc herniation. STIR may also be used in the sequence to detect bone marrow edema. In this sequence, tissues with short T2s appear dark and tissues with long T2s appear bright. The image on the right shows a sagittal T2 weighted image demonstrating decreased disc signal at the L5S1 level. The third sequence is axial T2 weighted. Axial T2 weighted images assess the relationship between the fecal sac and the surrounding bony and ligamentous structures, and they're especially useful for assessing spinal stenosis and narrowing of the lateral or subarticular recesses. Axial images may be required sequentially in the same orientation, which is called the stack mode, or some radiologists prefer to image the lower L spine and the lumbosacral junction with the imaging plane angulated and parallel to the disc space. This is called the angled mode. The choice of stack mode versus angle mode is a subject of individual preference. However, axial sections angled parallel to the individual discs may provide more accurate evaluation of disc bulging and herniation. All three sequences, sagittal T1 weighted spin echo sequence, sagittal T2 weighted spin echo sequence, and axial T2 weighted, evaluate the level of dehydration within lumbar discs based on increased signal on T2 weighted images, which is associated with degenerative disc disease. An MRI is capable of evaluating the hydration within the discs based on increased signal on the T2 weighted image. To interpret if the image is a T2 weighted or a T1 weighted image, we can check the CSF. If the CSF is bright, which means it has a high signal, so it must be a T2 weighted image. If the CSF is dark, which means it has a low signal, then it is a T1 weighted image. An increased signal on a T2 weighted image, or the darkening of the signal, indicates dehydration of lumbar discs or the loss of hydrogen ions within the discs, which is associated with degenerative disc disease.
There are other imaging tests that are also used to diagnose for degenerative disc disease. An example is a discography. This is a specialized X-ray test, and this assesses a patient's response to pain, which can evaluate the level of the degenerative disc disease. It is performed on patients who are feeling pain in their back, and their X-ray or their MRI findings demonstrate no pathology. In this test, a dye is injected into one or more discs, and the dye is seen on the X-ray, and it gives information about the health of the disc. Another test is an EMG, and this measures how quickly the nerves respond. Another test is a myelography. This test is limited to patients that have contraindications to MRI. In this test, an intrathecal injection of iodinated contrast is given to the patient. This test can detect nerve compression, and it can also detect disc protrusions indirectly. Some other tests are bone scans, and these can detect osteoarthritis, fractures, or infections. For a lumbar MRI, the patient needs to inform the doctor prior to the scan if they have a pacemaker or any other internal metal clips. If a patient does have a pacemaker, they may be referred to get a CT scan instead, or if possible, the pacemaker may be reprogrammed prior to the MRI so that it doesn't interfere in the scan. If the patient has claustrophobia, they will be given anti-anxiety medications. Another option is to sedate the patient. The patient will need to remove all clothing and all metal objects such as any jewelry, piercings, or eyeglasses. The patient will be wearing a hospital gown. The patient will also be provided with headphones to block out any excessive noise produced by the MRI machine. The patient will also sign a consent form. The duration of the lumbar MRI can range anywhere between 30 to 90 minutes. Throughout the duration of the exam, the MRI tech will monitor or control the bench as soon as a patient lays down, and the technologist will communicate with the patient via a speaker and the MRI machine. Also, while the images are being captured, the patient will be asked to hold their breath for a couple of seconds. For a lumbar MRI, a field strength of greater than 1.5 Tesla is used. A phased array MRI coil is utilized. This is because large portions of anatomy are being covered. An advantage of this type of coil is that wider portions of anatomy are covered in less time, which is very useful when imaging body parts such as the spine. Since scans are quicker, patient comfort is ensured during the procedure. For a lumbar MRI, a contrast such as gadolinium may be required to enhance internal structures on the MRI image. On a lumbar MRI scan, breathing can cause motion artifacts, and this produces ghost artifacts on the MRI image. In order to minimize motion artifacts, the patient can be immobilized, saturation bands can be used, as well as cardiac or respiratory gating. An effective MRI technique to reduce artifacts is echoplanar imaging. Disc prostheses and stainless steel can also generate artifacts, and this results in difficulty in analyzing the spinal cord. And on this image, it is showing a typical syrinx-like manifestation of the truncation artifact in the spinal cord. So a truncation artifact can be minimized by utilizing a smaller field of view as well as a larger matrix. It cannot be eliminated, however it can be minimized, and it is rare nowadays as a result of fast spin echo imaging and high field scanners. This is the link to our Kahoot.